I think the first question has to do with the preoperative embolization. Is that something that you guys consider, evaluate, or not? The second question is that do you use image-guided surgery during doing your procedure? So can all the speaker answer this question, please?
In procedure for meningioma, it's not completely necessary in all my case. Embolization.
So you never consider embolization? Okay. What about you?
Yeah, you use, frequently, the neuronavigation in all the cases. All the cases we tried.
Okay, Chandra, what about you? About embolization and navigation?
For petroclival meningiomas, I will do angiograms and try to embolize because you got supply from the meningohypophyseal trunk and it's all coming from the front. I also try to look for PL blood supply. So it tells me is this are the vessels going to be stuck to the tumor. So I will do diagnostic angiograms on not CP angle. I'm talking about petroclival meningiomas. I will do diagnostic angiograms, if possible, embolize it to see, because, to try and prevent continuous bleeding. I don't use navigation for CP angle meningiomas because you just go from landmark to landmark. But for petroclival meningiomas, if my plan is to do subtotal resection, then I will use navigation because it tells me how deep am I going, where do I need to stop, because it's hard to tell during the case how much you have really removed, because a surgeon's assessment is very poor. We know that intraoperatively. So if you're doing a subtotal resection, planned subtotal resection, decompression of the brainstem, I use navigation.
Thank you. Aristotle?
For complex skull-based tumors, meningiomas, I usually look at the T2 CTA. If there are indications that it's reads vascularization, we proceed with the DSA, and then I consult with my neuroendovascular colleagues and see whether it's feasible to embolize or not. So we have implemented it. For a neuronavigation, I was trained with neuronavigation from day one.
So you use it.
So I use it just to confirm things. It's good also for training of the residents as well. So correlate anatomy with what you see in imaging is what we need to do. And if there's a tool that helps them consolidate the image, it's not a negative thing.
You already answered. Matt?
Yeah, I use the navigation in most of the cases as a good educational tool. The placement of the craniotomy is sometimes very simple. You leave it to the resident on the sinus. It will be a good tool to verify where the sinus, because this is a whole lot of variation. It's of a great help. And it's available in the room. I have intraoperative MRI and I use the navigation. It gives a peace of mind, reassurance sometimes.
And what about embolization?
Embolization, I've rarely used it.
So what are your criteria to consider?
Some of the meningiomas that are huge and I need to know the supply, it reduced the time of the surgery if it's really, they could embolize the feeder for these meningiomas and some of the meningiomas.
And you do preoperative angiogram as petroclival meningioma as Chandra does?
Not in, but you mean MRA. I do an MRA or CTA. These are available technology and handy.
But in foramen magnum meningioma, I believe angio-CT is
adequate.
Because you can make identification which is the dominant vertebral artery. Is the only need to plan in my surgery.
Thank you.
In our practice, we do not use embolization for meningioma. For some other tumors, we use. And concerning neuronavigation, I think it was useful at the time of learning curve, but now I think it's not so necessary. Posterior fossa is very anatomical area. So if the if a neurosurgeon is very well oriented anatomically, there is no sense in
Yeah.
neuronavigation.
Yeah, I don't think that neuronavigation has any drawback, especially if you use the microscope focal point as the virtual pointer. So you don't need to, get in and out and everything. If you use the
Yeah.
microscope focal point as the virtual pointer, really you can immediately, it's very, very straightforward. Thank you.
We went from extensive skull-based surgery approaches to all of the speakers talked about more tailored sort of approaches. And Professor Sami's taught us all that the amazing stuff that can be done through those approaches. But yet what we're seeing across the board is we're seeing that more patients with residual tumors. And I guess the question is, have our goals changed, or is it a limitation of our training, this next generation? Because I mean, we're seeing more and more of these patients coming back with a larger amount of residuals and more complex tumors because of potential adjunct treatments that we've that they've been given. So just curious what the master panelists think.
The question is,
So why? So we're seeing more and more patients with residual tumors that are being referred to our centers.
okay,
In the past, we were doing these extensive skull-based approaches, but again, Professor Sami taught us that you can do these very, very elegant, beautiful operations with gross total resections. Are we seeing more of this because our goals have changed, or is it because it's our training, training methods have changed for this next generation?
Yeah, I think the opposite, because our philosophy is to complete the resection of this tumor that I present here, the posterior fossa by the retrosigmoid approach. No? So we think different. In our case, we will not increase the remnants with our surgery.
I think Professor Sami wanted to say something.
I would congratulate to all of you. I enjoyed very much a great section, wonderful presentations of all varieties of tumors and variety of also technique. I would like to give some advice. One is that we should learn some principles in general. It is not related to bias of somebody to do something. First of all, when we are looking in the pathology, okay, that is our enemy of patients. Please try, with your experience and knowledge, think how I can reach pathology without harming the patient by my approach. Can you understand that? Please keep in your mind when you are doing that. This is essential. Second point is, when I arrived at the area without seeing any nerves, vessels, cutting some veins and so, you must have only one goal. How I can enucleate this tumor without going around the tumor. Is that clear? Because this is principles that I have learned, God gave me to learn it. Because both of them are a guarantee for patient, you are not harming the patient. Once you enucleate, because the tumor, wherever it is extending. What is extending? Is bringing pressure to all the structures. Nerve vessels, the vessels is as stretched, and every structure is under pressure. You have to take out the pressure of all the structures around. And we are discussing about approaches, but we are never discussing about this fact, why I am going this way to the tumor. And this is the crucial principles of my life I think I gave 1 hour lecture only on that, but I said it is very important. The next point is, it is fantastic that you learn how to expose the scalpels from below, see everything to panorama. Wonderful. This is an advancement, yeah. But on the other side, you are losing all options that you could have from other side, what you have not learned, because you have not learned long time how to operate from other side. And this is the dilemma that we have generally in new generations. Now, when we combine both together, is a paradise. Believe me, creating. I say once, when you want to fly from Frankfurt to Houston, the company said, we are a very safe company. 99% of our flight is safe landing. Only one fell down. Are you going to take that? This is something you all, I am sure you have also a lot of complications, 100%. But you have to change, not have everybody come today to me for surgery. He has to go home, not worse. Whatever I do, that is my principle. And that is the reason, don't be proud if you had an approach, it is working, but 2, 3 of them died or are hemiplegic or has problem. No. I have changed the best approaches. For example, Presigmate approach. I was very active for a couple of years. John, you know that very well. And then I had 2 cases of vein of Labeda, I had to calculate and so on at hemorrhage. The patient survived, but it was complicated. And I said, no, never, ever I will do that. That compromise one single vein. And therefore, my approaches are now limited to areas that I can avoid any nerves, any vessels, just by the approach. And that was in my heart to say that if you learn from the other side that an olfactory meningioma, you can finish it in 2.5 hours from above, then you will not go, then remove the entire paranasal. And by the way, if you remove the entire paranasal sinuses to get such a panorama, the patient is forever is disabled because any things what happened in paranasal, the God created our paranasal sinus to protect us from the environment. And we are taking it completely out. I use many cases I have done endoscopic, but what I do that, I go in the midline and the paranasal mucosa are for me holy. And I try to push that back, right and left in order to come to the skull base and remove that bring up back the paranasal sinuses, that everything is protected. But I admire you also that you did this big hard job and to learn that and to bring it further. But please try to come back to the reality. And I must tell you, for the frontobasal surgery, the best what I have seen in the last time is if you learn both. But a small frontolateral, you can from above close it, 0 fistula, not 30% fistula, all when you are only coming from through the nose and then removing that. And that is my advice. I'm so sorry that I'm talking because I am not going to talk in that field in my lecture. And I am using that to tell you what is in my heart. Sanchandra, really, he's for me one of the best pupil of my pupil. Is that correct? And he has done fantastic. In one of the meetings, I killed him because he was talking about transcondylar approach. You remember that? And at that time, he has operated, I think, 11, 12 cases and was very enthusiastic. I was proud of him. I told at that time. And he said, yeah, it gave me place. And so in his age and in his experience was absolutely correct. But I couldn't accept that because I had 120 cases of foramen magnum tumors and I have removed, but none of them I needed to remove the transcondylar approach. And I said, to somehow I said, look, I am not fighting against you, but these 400 people are seeing here, they will go home and they want to, in every patient, go through the condyle. I want to avoid that for them. That was the reason. Therefore, you all are the elite of medicine in most difficult field. I admire you all, and you are doing fantastic job. Please, but come slowly to the reality and come to the simplicity, as Imad said, and avoid extensive. Don't believe if somebody demonstrates an extensive cases with all approaches. He is a beginner because he doesn't know what to do, in this. I thank you very much and thank you all so much.
Yeah, just a very, very brief. Okay, do we think that we can cure meningioma? I believe the longer you follow up, doesn't matter what you do, in skull-based meningioma is going to come back. And the longer you follow up a meningioma, it will come back. Doesn't matter which approach you use, what extent you excise it. I think once meningioma for life meningioma. Please see after 30 years, all your cases, there will be tumor recurrence.
Yeah, that's very good. That's apply also to convexity meningioma. If you follow convexity meningioma, as people in in Northern Europe can do due to the healthcare system, you see that 20, 25 years later, even convexity meningioma are completely removed, you have at least a 15% recurrence. So that applies even more so to skull-based meningioma. Yes, go ahead.
This is a question for my Canadian, Hellenico-Canadian colleague. So I am very obsessive compulsive, and I hate CSF leaks. And because CSF leaks, just because, not because of my ego, is because CSF leak cause nosocomial infections, that are usually gram-negative, hydrocephalus, chronic. Again? Okay. Chronic headaches and, delay professional return to work and everything. So I just want to know what is your way of closing up the extended endonasal approaches. I usually, I was, brought up by Ted Schwartz, who likes the gasket closures. So I'd like to know how you close.
Yeah, thank you. I think that's a very important comment about the CSF leak, and it's the struggle of endonasal skull-based surgery, how to minimize this important complication. We've become better over the year. This is what numbers show, but still, there is much more to do. For the expanded cases, our approach is fascia lata. So let's say we do a tuberculum sella meningioma, we have high flow leak or craniopharyngioma. We take fascia lata. We do in fascia lata inlay, fascia lata onlay. Then, I sometimes use a middle layer where I tack under the bone. So I don't hesitate sometimes to do 3 layers, and then nasoseptal flap, some Surgicel at the edges, tissue glue. And it has been okay so far, reasonable results. The more expanded approaches like chordomas, we usually use FAT a lot as well, because there's the depth and the CSF leaks are much higher for transclival approaches than the other approaches. For transclival, sometimes we use intraoperatively, we put it intraoperatively and it stays for 3 days. For some very large skull base resections above 3 centimeters, we might use it. Or if there are preoperative indications like T2, a high signal edema, and and a meningioma, it's a warning sign. So in these cases, we do. Like for esthesioneuroblastoma or for craniofacial resections, we usually don't.